Hello everyone and welcome to today's Connect and Learn webinar, the MARAM alignment of the Victorian AOD intake and AOD comprehensive assessment. Before we start, I'd like to acknowledge the traditional custodians of the land where we're presenting from today, the Wurundjeri people of the Kulin Nations. I would like to extend my respect to elders past, present and emerging, and to those First Nations people who might be watching this webinar live or as a replay. If you're in Victoria, I would be assuming most of you are at home today, so welcome everybody. My name is Rebecca. I will be the facilitator today. This webinar is part of a series of Connect and Learn webinars designed to support AOD clinicians throughout regional and metro Victoria. And we also welcome all of our interstate and potentially international viewers. These webinars are hosted by Turning Point and funded by the Department of Health in Victoria. We really like our webinars to be as interactive as possible, so please do ask questions along the way. Part of my role will be to share those with our presenters. You'll be asked along the way to make comment, and you have two icons that we'll be using today, a blue hand to ask questions, and you can ask questions throughout and I'll forward them on to the presenters. You also have a purple icon where our presenters will be asking specific questions and some polling type questions, and at that time we'll ask you to use the purple icon. We would love you all to stay until the end and complete our exit survey so we can get an understanding of what your needs are. But let's move forward and introduce our presenters today, Carmen Harris and Stephen Hurd. Carmen has got extensive work history in health and community services. Much of this has been in operational coordination and management roles. She really enjoys supporting staff and agencies to provide opportunities, advocacy and assistance to vulnerable people. Her career has spanned community development, disability education, veteran services, mental health and men's health. For the last 3 years, she's been managing strategic projects and initiatives for statewide services for Turning Point and Spectrum. Her experience in family violence programs was established in the management of clinical operations for crisis services. This included Men's Line, which is a soft entry point for men with relationship problems, including those who use family violence. Our next speaker is Stephen Hurd, who is the Specialist Family Violence Advisor for Turning Point and the Inner East Catchment of Melbourne. His role is to support AOD agencies to build family violence capacity and support the alignment to the MARAM, which Stephen and Carmen will be talking about today, which is a multi-agency risk assessment and management. He is passionate about supporting Turning Point and its dedicated staff to feel confident in screening, assessing and managing family violence risk. Stephen is excited to progress family violence capacity building in light of this refreshed intake and assessment tools. Stephen has deep experience in the family violence space, with skill in working with male perpetrators of family violence. He's co-facilitated men's behaviour change groups. So thank you both, Carmen and Stephen, for your time today. We're really lucky to have you. Over to you.
Thanks, Rebecca. And it's a great delight to be here to talk to the AOD sector about the refreshed tools and their alignment to MARAM for victim survivors. Basically, today we're going to talk through a range of sort of background to the project, etc. But I just want to hand to Steve to also welcome those with the lived experience of family violence.
Yeah, thanks, Carmen. Just to build on the acknowledgement of country, just also like to acknowledge all people across the continuum of age who have experienced family violence and recognise that women have the highest risk of lethality from family violence. It's for these people that we are here today to learn and grow as health professionals, so that we can support and respond appropriately. We acknowledge the lived experience in the room of those who have loved, known or are someone who has been affected by family violence. And if needed, we encourage you to access family violence support by liaising with your manager or specialist services in your community. Thanks, Carmen.
Thanks, Steve. So I guess all of this work is to support victim survivors, and I know that everybody here will have a shared passion for providing the best possible service to their clients. And I guess that's what unifies us around this and our efforts on this. I'm really keen to see who's here today and test the public chat, which is going to be our way of polling you, getting your input and your interaction around this program. Yeah, just keen to, if you can, type into the chat where you're from and what your role is, so that we can get a bit of an idea of who is here with us. I can see Faye on one of the chats here saying there's no audio. Has anybody else got that problem? So the public, the chat is the purple icon there. Great. Okay, people can hear, that's good to know. Program coordinator at Shark, fantastic. Great, thank you. I can see some of those coming through. Cicada, fantastic. We've got Thomas Jones, an AOD nurse, ED nurse. Wow, what a broad range of people here. Thank you so much for entering this in. They're all flowing through now. They're going so fast that I actually can't read them all. YSAS, we've got Odyssey. That's fantastic, great. And ideally we would have loved to have a verbal chat, but the platform doesn't allow for that. So this is how we're going to interact with you. So I can see all of these here. We've got Youth AOD, we've got Gateway Health, we've got Gippsland Lakes, we've got, wow, CoHealth. There's just an enormous number of people here. Thank you so much. Now, hopefully, you will also all be able to see the chat so that you can see the questions that are being asked, so we don't have to double up. And you can also kind of get a sense of what the audience is kind of thinking and asking about. But I just note here that we're transferring these over into the Zoom chat, and that might take a while. And I wonder whether with this there actually might be too many people here for Rebecca to transfer them over, but I can see them here. So thank you so much for putting those through. Right, so next slide, please. Okay, so I'm just going to talk you through the background to the project. You may already know this, you may have heard this before in previous presentations, but the MARAM framework was established under law, Part 11 of the Family Violence Protection Act, as part of the findings of the Royal Commission. There are a range of things implemented, including Steve's role as specialist family violence advisors. And part of MARAM, I guess, is this maturity model and the staged release of the different resources. And at the moment, we don't have the perpetrator resources, but we have had the victim survivor resources released. And this is, I guess, the way that it ties into this project is that it's about ensuring that screening and identification and if necessary, risk assessment and safety planning for family violence occurs routinely, just like it would with suicide risk assessment. So it's getting implemented across a range of settings, and AOD is in scope. So this is us sort of doing that piece together for victim survivors, getting that the screening and identification happening on a routine basis. And we'll talk through a bit more on the next slide, please. So last year, Turning Point was asked to conduct the project. You know, we have an interesting situation in Victoria where we have standardised intake and assessment forms and a clinician guide, and we've actually got an online guidance package as well, which has been updated. And so it was all sort of done together in one bunch. Now, we've got the online guidance package on the Turning Point website, but I just want to note that this doesn't replace MARAM Brief and Intermediate training, which is the level that we're required to train to now. So basically, all staff, clinical staff, team leaders, and potentially others too who may be providing guidance or operational management to get to the brief and intermediate training. Now, there is some online training coming out in the near future, which is packaged up in a little bit more of a succinct way for the sector. Previous models, which are out at the moment, were found to be a bit cumbersome, hard to get to, modularised and difficult to complete. So the state government funders are trying to address that with this new package. Also, the forms will reference the family violence information sharing schemes and the child information sharing schemes. So that's built into this review as well. Next slide, please. All right, so I'm going to hand over to Steve here, who's going to talk about some examples of using the FIS and the SIS. So this is just a little, I guess, a selling point maybe for those things, and maybe ask you too how you might have used them. Steve.
Yeah, thanks. Yeah, thanks, Carmen. Yeah, the use of FIS and SIS are really there to increase the safety of women and children, and also increase the visibility of perpetrators. Probably one of the most striking examples that we can say at intake and assessment is the further inclusion of more questions around family violence intervention orders, where we ask more about the status of the person being an AFM or an affected family member or a perpetrator, and the details of that order that they're a part of. And depending on the nature of that conversation, how that goes, their willingness to talk about the order or their knowledge around the order will then help us make decisions around what we can do next. And one of those things we can do is request a copy of the intervention order. And that might be very helpful in just clarifying details for an affected family member, and also advising them that it's for the respondent to comply with that order. Or it could help us with a respondent who's unclear as to what they're supposed to comply with, so we can get that order. Another type of piece of information that we could that we've used in the past is just to seek a release date from incarceration for a perpetrator. You might have a female victim come to the service, but their partner's still in jail, and unknown release date. Just to throw out there to you, what type of information have you requested using information sharing scheme, either FIS or SIS? There's a whole range of organisations that are classed as information sharing entities within the MARAM framework that allow us to share and request information based on consent regulations. So if you just want to share in the chat, just to say what discrete information you've found that's been useful for your treatment planning processes.
That'd be great. Also noticing some comments coming through while we're waiting for people to give us their answers there. There's a few things noted here. Someone's mentioned that withholding medication isn't included. We'll be collecting information via the chat. So we'll use it as a data collection tool. And when we review for the perpetrator aspects of the MARAM, we will have another opportunity to tweak this. So your input there is most welcome and very much appreciated. All right, we're not seeing much come through on the FIS and SIS that I can see in the public chat at the moment. And maybe that reflects that it is pretty new and we are just starting to use these. I think that the key one that that really rocks me is being able to tell a victim survivor when the perpetrator is getting released from prison, or we can check on whether IVOs are breached. I think these things, and I'm not a clinician, but I think these things are incredibly important and useful to our clients. Someone said here, FIS and SIS info is terrifying. I understand that there's actually some reservations and some concerns about using those schemes. Yet, hi Steve, Ben, he's saying, I have requested the release date of a perpetrator in prison from the court. Fantastic, and how useful and the peace of mind that that might give somebody. Haven't used the forms yet. However, have talked and gained consent to request IVOs. Fantastic. Haven't used it much. A few people are saying it's not incredibly surprising at this stage. Yeah, great. Yeah, and I think also talking to clients about our responsibilities is a nuanced, it's a nuanced thing, isn't it, Steve? And what would you advise around sort of brushing up on that aspect?
Well, I guess brushing up talks to what training's available.
Yeah.
But I think in these early days, it's about really reflecting on what information that we do have, or we could request. It is going to increase safety for our for victim survivors. Obviously, in line with the legislation, I know that in my workplace we have a couple of layers of administration to go through just to help coordinate it in those early days. But it is supposed to make more information more freely available, and helping us to ascertain with our clients, work with our clients a lot better around breaching of orders, for one example, just so we know what we're actually dealing with. And so our treatment plans, discharge plans can take that into account.
There's a really interesting one here that says we receive anywhere from 40 to 70 FIS requests per month, mainly from the Orange Door. We have used the form to request SIP reports from the Orange Door to inform perpetrator risk.
Yeah.
So there's some exciting parts to this, as well as probably some daunting parts to sort of work through in your supervision and training. So just want to acknowledge that as well. All right, next slide, please. All right. So I'm finding all that quite fascinating, trying to read through those at the same time. So the consultation process was multi-layered for this one. As with all past projects where we've refreshed the tools, not that I was involved in those, but we have had a AOD sector input process, and this time there were several workshops, etc., with the working group. We used polling. We did a whole bunch of kind of innovative workshop platform type things to really gather as much information from the sector as we could. So we had a high volume of input from those working groups. Those working groups included people from intake assessment roles, operational managers, metro, rural, regional providers, specialist family violence advisors from the AOD sector, VADA, and also included Department of Health funders, subject matter experts, Family Safety Victoria, No to Violence, so a cast of thousands. And really what I would say is that we, Turning Point, really advocated for the sector, and most of the feedback provided was incorporated. So that was, I feel, that group really engaged really well. They provide a lot of feedback and still do. We're still getting feedback on the tools, and although we've sort of we've closed that feedback process for the current round, we're still quite happy to collect information for the next review, because we know how important this is. We also know that it's you know, it's quite nuanced work, and that the sector really needs to be heard in the changes that come through for them, because this is practice essentially. So can I get the next slide, please? Great. Above the AOD sector working group was a project control group that included Department of Health funders, Family Safety Victoria, and from those expert sort of areas, we were provided with subject matter experts in MARAM, FIS and CIS, Child and Family Services, and a range of other areas as it came up. And actually, a lot of that was around the clinician's guide as well. So it was great to be able to sort of draw on, I guess, sector-specific expertise. But then also, I'm really excited to tell you that we were able to also include a review for consumers that had both a lived experience of family violence and AOD. So that was really, I think, a valuable process too, that was constructed for us by Shark, and Odyssey helped us in actually making that happen with some consumers that had both of those lived experiences. And what they brought to it was integrated throughout the tools, clinician guide, etc., and the online guidance package that accompanies the intake and assessment tools. They talked about sort of needing to feel like it wasn't a tick box exercise, and that it sort of all the issues were kind of talked about together. And I guess as clinicians, or the clinicians here will know that, you know, there's a whole lot of empathy and therapeutic alliance that needs to happen with consumers, and it's great that as part of MARAM it really does talk about being led by the client. So Steve will talk more to that because I'm not a clinician, but that is also, as I said, integrated throughout all of the different pieces of work. Next slide, please.
Yeah, so I'll take over again, Carmen, just about training.
Yeah.
Yeah, Carmen's already mentioned the two other resources that come with the tools. One is the online guidance package and the clinician guide. And just to reaffirm that the online guidance package is there probably more for newer workers, but it doesn't substitute for MARAM training. The basic level of training that AOD services are at is at the intermediate level, and so it would be by default the intermediate level risk assessment that would be done in most circumstances. We do talk about the brief a little bit later. And it's also important that when MARAM trainings come out, and they've come out in a variety of forms over the last couple of years, that they get prioritised and sequenced, and the right people get to do the right training. Yeah, next slide, thanks. Yep, so the training that has been available to date has been face-to-face training. A couple of years ago, the online 4-module webinar series for brief and intermediate that was predominantly put online through COVID last year. And then very soon will be the online self-paced package, which will cover the shared understanding of family violence, how to use the brief and intermediate risk assessment tools, how to undertake risk management and safety planning as well. So in some sense, it is going to be the default training, but if you did the brief and intermediate some time ago, you might like to access it in your own self-paced manner, just as a refresher. One key aspect of the training is that the tools exist with screening and with safety planning, and as an offshoot, the risk assessment is done separately, and it's not expected that you do the actual MARAM risk assessment unless you have been trained in that particular MARAM intermediate level training. You can certainly do the family violence screening and safety planning, presumably adopting your own existing business practice or business as usual practices. So it's really important to understand what your current practices are regarding responding to immediate risk and family violence risk in general, and then really building upon that to really incorporate skills and knowledge around undertaking that intermediate level risk assessment. Next slide, and I think it's back to you, Carmen.
Thanks. Thanks, Steve. So as I said, it's an interesting situation in which we go forth together on this path because of the joint tools that we all use across the sector for intake and assessment. But I guess there's an acknowledgement that we do this in different contexts. Some organisations will have family violence staff on site, some won't. Some will have, you know, a high level of family violence competency across the team. Perhaps everybody is very experienced, and then others maybe not so much. And that could be on an individual level or an organisational level, as far as how progressed or how advanced the family violence understanding is. And we all need to get trained in MARAM brief and intermediate anyway. So I guess what we really need to ensure is that our organisations are providing the right support, that they're supporting staff to go to the training, and that not only that, that there's some strategies there to actually support people coming into the work, whether it's a program of supervision, processes within the organisation, guidelines being updated. But I think things like reflective practice and and other supportive methods for clinicians are really important at this point, and that we all, I guess, that everybody really does a bit of self-evaluation at where they're at, and doesn't really practice beyond that and prepares earlier for their level of expertise. And I think that that's what Steve was sort of saying before. The other thing I want to acknowledge here is that we also face some challenges in implementing this. Clinical challenges we've spoken about or touched on at least, and I've put a few from the question from the chat in here for Steve to look at in a minute when we get to question time. But also a lot of clinicians and managers have raised about the time that it takes to do this work and that it's not funded. And I guess the answer is that we need to demonstrate, our funders have said that we need to demonstrate that we're using the MARAM for them to review whether there's an uplift in funding. That's what we've been told. And as I think I've mentioned, VADA is heavily involved in this and will be surveying the sector around this, but also in your VADC reporting, it's noting that MARAM has been used. The other item being whether the person is a victim or a perpetrator. You can also put not disclosed there if you're not sure or was unable to be asked. So there's also, I guess, us quite willing to listen and take feedback for the next round as well. And we always advocate for the best interests of the sector. Next slide, please.
Yeah, and that's back to me for a few slides. Just regarding the expectations at intake and assessment. So really the nature of intake now, it's very much AOD focused still, but certainly there's a requirement for screening for family violence and taking appropriate safety planning steps as and when it's been identified. And if family violence has been identified, it's recommended that you undertake a MARAM intermediate risk assessment. So it's not a mandated requirement, but it's a recommendation based on other factors that might exist within that interaction. And then it's necessary to complete a safety plan if one has not already been undertaken. The client may disclose they've been engaged with specialist family violence service and already have a safety plan. Next slide. At assessment, it's a little bit different. Certainly you'd be leveraging off what has been done at intake, and that may still involve screening if it wasn't done at intake. And if family violence is identified or disclosed by the client at assessment, then you should undertake a MARAM risk assessment. So that's been identified as the more appropriate timing to do that assessment. It will take extra time, but you do have that time with the client. There are qualifications to doing that assessment. It's around safety, time, whether they're alone, whether the client's able to do it at that time. All come into play as to whether you do get that assessment done. Certainly doing the best you can along the lines of immediate risk assessment and completing a safety plan are very important. And if there is immediate risk concerns, then the directions around that are very much around getting advice from your supervisor, team leader, potential to call safe steps for a secondary consult, if not a warm referral, or police if necessary. And that really involves immediate risk. Next slide, please. And just before we move into the forms themselves, just a couple more slides. It's very important to ascertain that it is safe to ask about family violence with the client. And that's around it not being perhaps a safe environment if it's over the phone, and we've all learned a lot over the last 12, 18 months around the nuances and delicacies around, or sensitivities around safety checking at home, because we're unsure as to what's going on. But also to be client-led, meaning are they willing to disclose any discussion around family violence? It could easily be that you get a sense that family violence exists, whereas the client's not wanting to talk about it. And that's what really being led is all about. It's not about forcing forcing a client to talk about family violence if they're not prepared to, not wanting to, and it's not in their interest to at that time. When it comes to the intermediate or the brief risk assessment, admittedly there's not much difference between them, but the brief does focus on the high risk factors. And so if all you can do are the high risk factors, well, that would be great. If you can qualify just in conversation as to what experiences the person has had around violence and identify those as high risk factors, and that's going to really help inform the risk assessment. And then undertaking a safety plan, keeping in mind that they may not be able to take that with them. If you're doing a face-to-face session, you may fill it out on paper so it's retrievable at a later time, but the client may not be able to take it with them for safety reasons. And again, there's the concerns around immediate safety and what action you should take. Certainly business as usual practices will moderate that, but also it's just restated there just to qualify. Next slide, please. I just thought I'd bring this to your attention. This comes out of a document called the MARAM Screening and Identification Practitioner Guide, released by the department. And it gives a nice, neat 2x2 grid in what to do in cases of immediate danger and a client's wanting to undertake support. And certainly that top right corner, which has got the most number of steps, that is probably the most problematic area for clinicians. Around immediate danger, but the client's not wanting to take up any support. When I say client, I mean a victim survivor, someone who's experiencing family violence. They may not want support. And so they're a list of actions that you can take. And certainly, even if there's no danger, the bottom quadrant, if there's no danger, but the client's not willing to receive support, there's still offerings of support that we can make and ensuring that they know that when they might be ready, that we'll be ready for them as well. So I'd really just like to point that out because it gives a nice succinct description. Please Google that, or if you get the slides too, look at the link at the bottom of the slide. All right, so we'll just move on to some general questions and answers if we've got some a bit of time before we go to the form, Carmen. Before we go to the intake form?
Yeah, and I've actually gone over to the chat and popped a whole bunch over to you, Steve. That might look a little bit overwhelming, but I've tried to copy over most of them. If you could just skim through those and then pick out what you think we haven't answered. I just wanted to note that I'm noticing a bit of a theme in the chat around feeling overwhelmed and that it's a lot of work. The other thing that we have been given as a provision is the use of brief interventions, which are up to 3 hours of support, so they can count towards your targets. Single session family can be used as well. Bridging supports can also be used. So I guess what I would encourage you to do is make sure you record the time that you're using to do this extra work, if that's what it's resulting in, and that we are also reporting that extra work through VADC and through the VADA survey. So make sure that you chime in, get involved in that when that comes around, because we really need to show the department that we're actually doing this work. And although you might be feeling overwhelmed, and I'm seeing that as a theme in the chat, I just want to commend you that you're actually doing the work. We know that AOD workers deal with family violence anyway, and they have been for a long time, but it's just incredible to see that you're obviously actually getting in there and doing the work. So I just want to commend you for it, even though it may be under tough circumstances. I noticed too that someone said there's 3.5 hours of extra work on one client there. You might find in your area that you're holding family violence risk ongoing as well. And we know with complexity and where we're doing shared case management, or there's a care team involved, you also have your CRC as well, your care and recovery coordination, and that's for any complex case where you need to do more of that care team coordination, etc. as well. So just want to encourage you to make sure you record all your MARAM work including your case notes, and also report into that survey. And I'll just, Steve, did you want to comment on any of the questions that I've copied over there?
Yeah, just a couple of quick reflections on the questions, but one that says, can government departments be contacted via FIS for information, e.g. CSA for evidence of financial abuse? Well, as long as they're an information sharing entity and you follow the correct protocols around family violence information sharing, then yes, you can share information or seek information. It's really important though to understand the nuances around the information sharing scheme, and there should hopefully be champions within the organisation who do understand that. It's supposed to increase the availability of information and the ease which information can be shared and requested. It doesn't seem like that given the nuances, but when we talk about family violence risk, we can seek and we can share any information that we deem as really impacting family violence risk. And that's probably the short answer, and as long as the body we're going to is an information sharing entity, and there are lists of those that comply with that.
There's also a lot of guidance in the clinician's guide around all of these areas too. So I just want to highlight that, and what the clinician guide will do too, as well as providing a bit of an overview if you're not sure what your agency's responsibilities are. That's in the clinician guide. The clinician guide, in a sense, is a bit of a policy piece. So that might be something to share with your organisation if you feel like they're sort of falling behind in setting up policies and procedures, etc. That kind of is the overarching guidance on it. So that might be a good one to flag with them. That guide will also point to other resources in MARAM. So it'll give you a bit of a taster and then go and check out this one for more information. See, I'm just responding to some of these. You keep going.
And a phrase that the department used to use, I haven't heard it for a while, is that MARAM is a maturing model, meaning we improve our practice incrementally over time, and I think that's a way to move ahead with this huge task, because it is a huge task. We're asking the AOD sector the AOD sector is being asked to respond to family violence and prioritise that alongside AOD risk. But to do that, it's going to be small bites at a time, small steps at a time. And certainly there is the overlap with the last question I've got here regarding organisational policy versus MARAM directions. So there are MARAM framework and legislation and policy guides and practice guides. The organisation has to put work in to really reinvent what that looks like in your space, in your particular space, as we talked about, as Carmen talked about before. We're doing it together, but we're doing it differently as well. We have different services, we can have different treatment profiles that we might adopt. So it's for each organisation to go through, not just at the clinical level, but from the top down, as far as what MARAM looks like at each level.
Yeah, and I can see a lot of,
shall we move on to the forms?
I just wanted to note, I can see a fair amount of frustration in the chat around the amount of time. Yes, we are talking from an AOD perspective. These intake and assessment tools that we're talking about are AOD tools. And I understand that, yeah, I mean, I guess we don't have control over government policy. We facilitated a project and we advocated for the sector. So I understand if there's some frustration around this. What I would suggest is you feed this into the VADA survey, because as I said, as much as we try to advocate for the sector, we actually don't have final decision making on this project or any of that sort of stuff. We've just basically tried to do the best we can with what we've had. So yeah, I'm just wanting to comment on that, and that seems to be one of the main frustrations in the chat. All right, okie dokie. So should we move on to the next slide? So that was basic. Was that about the? Do you think we've covered all of the questions that we can answer today, Steve?
Yeah, I think pointing out there's an overwhelmness that comes through.
Yes.
Without reading all of them directly.
Yeah.
There is frustration concern.
Yeah, and we'll get the chat transcribed too, and we'll feed what we can back over through VADA as well. So quite happy to do that. All right, so now we're going to take a look at the intake form and just walk through the changes to that one. So I'm going to do a screen share, which just going to pull up the tool now. And I'm ready to go on.
We have received your slides.
Thank you. All right, great. Can you hear me now?
Hello, Rebecca speaking.
Good to go? Okay. Steve, can you hear me?
Yeah,
Just checking
yeah.
Sorry, I'm just hoping I'm not having difficulties here, technical difficulties.
No,
So this is the new intake form here. It's the fillable. We had some feedback on the fillable not having enough space to type. So we've tried to do some changes with the graphic designer. We've had some feedback. Not everybody's liked the changes either, but we've had to do the best we can with what we have as far as space. These forms are already quite crowded and there's a lot in there. One of the things that Sheridan Byrne, our colleague at VADA, often says is that these are not a tick box or a verbatim type of tool. They are meant to help with data collection, and that actually your conversational sort of integrated sort of risk assessment is what is obviously preferable. We've added a bunch of stuff in the demographic section that was part of the working group feedback, including a request to put in private health insurance. And that was because if a person has private health insurance, it might be quicker for them to get into rehab. So that's why that one was added there. Steve, did you just chime in anytime you like about the changes here? But there are a few other minor changes in here. Safe to leave voicemail text messages. Does anyone else have access to this phone? Those sorts of things are prompts as well, aren't they, Steve?
Yeah, is it safe to send mail to this address? Yes or no?
Yeah.
That prompts a conversation.
Yeah. So also in here, we've tried to include changes that will give you indicators of family violence, men's behaviour change program, noting family violence services. It is a reasonably crowded form, and we are aware of that, and it's a difficult job to try and integrate changes. So as I said, we've done the best we can, but we can still take feedback into the next phase of the project for perpetrators as well.
Let's go down a little bit, Carmen,
Yeah,
down
sure.
to item number 11 on this page.
Yeah.
There we go. Other risky drug practices. One of the options put in that list is injected by another, which may or may not point to an element of substance use coercion. And I noticed someone made mention of medication withholding.
Yes.
As an issue, that's another substance use coercion strategy.
Right.
So that might come up, and it might come up in the conversation.
Yeah.
I might lead that conversation.
Yeah. Obviously, these aren't to be sort of read out, but they're things to listen for. Down in this part here, risk and complexity, we notice that there is, so we've tried to include, I guess, the items of the form that were already here, along with some new items around whether the person is an affected family member, etc. To try and identify at this point whether the person's a perpetrator or a victim, survivor, but we understand that that actually might be a little difficult at intake. So it's just here as really something for you to listen for. Did you want to talk about this, Steve, about this section at all?
Only in the sense that it tries to just normalise the effect of having an intervention order. It doesn't highlight the fact that we're talking about a victim or a perpetrator, but it's really just getting information around what that person believes, their order says, because they will play a big part in our information sharing and our risk management later on.
Okay, and I guess there's some words around expectations at intake. We know that at intake risk is mostly flagged for assessment, and you deal with I guess the concerning risk that your clinical judgment tells you need to deal with then. So what we would say is, you know, if you think about the process that you use for suicide risk assessment, it really can mirror that and also that if you're not trained in MARAM, you're not expected to use the MARAM tools, but the guides and prompts in here are designed to help you draw out information. You also see the guidance down here if you're concerned about immediate safety, escalate in this way. Down here, your summary of needs is another spot that you might put in information around the family violence risk. You might hand that over to the assessing clinician, and if you are doing that, you would want to think about the skill set of that person and use somebody that you think can manage that risk as well. Steve, did you want to talk any more about this?
No, not really. Someone did ask what are the stats on those in the AOD sector with clients with private health. I guess from my assessment, not many, but there are situations where a person with private health, they may get access to treatment sooner.
Yeah.
System of want to detox or whatever that might be, a 2 or 3 month wait.
Yeah. So that's why that one was added. Okay, so that's that form. What I'm going to do is I'm going to pop out of the screen share and we'll look at the questions in the chat because I can't see them right now, and then see if there's anything else we can address now. So we'll just go back into the slides. Rebecca?
Carmen, you have to stop the screen share.
Oh, thank you.
No worries.
Great. Okay.
Probably one thing we haven't mentioned or promoted much, and we should do, and I know MARAM does and the system does, is the need for clinicians or the support clinicians can get from secondary consults, from discussing in supervision, from accessing their local specialist family violence advisor when talking about family violence risk that they've come across with their clients. It's really to promote that one-on-one learning with specialist family violence services for secondary consult, which can be done in a de-identified kind of way, a narrative way, if you've got any concerns. The system is gearing itself up to increase its numbers around that secondary consult. So as a clinician, you should feel free and feel empowered to be able to ring, say, No to Violence, or ring your local specialist family violence, or the court, or another family violence body, because you have a secondary consult query regarding a client. That should become an accessible part of your practice.
And I notice here a lot of talk about the time taken for an intake. I do believe it's a 20-minute intervention, and then somebody has correctly added here that yes, you can actually add extra brief intervention, etc., if there's complexity, and that's with any type of risk. I wouldn't say it was just family violence risk. There's no reason that we shouldn't be counting the time that we spend with clients, particularly if we're looking at the multi-layered complexity that AOD clients present with, and we want to do that little bit of extra work to make sure they're safe. I think that that is absolutely something that agencies would support, and you can record an extra treatment type to reflect that. So just supporting that. All right, so I think that's about all that's come up around that tool there. All right, so can we go to the next slide, please? All right, so now I'm going to share the assessment form and we'll go through that. It's obviously a lot more detail in that form because assessment is an assessment and intake is really often a very supposed to be quite, I guess, a brief interaction where we collect key information to work out whether a client needs to get an AOD assessment or where they might need to go. I'm just going to get that up now. All right. So that's up on the screen. Can you see that, Steve?
Yep, that's fine, Carmen.
Great. All right, so if we scroll through here, the first thing you might notice is the optional modules. These are those extra bits you might do to explore certain areas in more detail. We've put the links to the page where you can get to all of those modules just to make it a bit easier. And also to the MARAM tools and practice guides for victim survivors, which have replaced Module 10. So Module 10 is no longer in use, and you're encouraged to use the brief or intermediate. The intermediate tool is the benchmark, and the brief for those circumstances that Steve spoke to. So you can see here, there's also a list of those here and a little descriptor to try and help people find them. Down here, the first part, we haven't had any real changes. These boxes should now sort of provide you with more or less endless typing, which gets smaller and smaller. I know it's not perfect, but we tried to improve on the last lot of changes. Just note it will come up different in different PDF viewers. So if it's not working in one, perhaps talk to your ICT department about what a later version of the PDF viewer is. This hasn't changed down here either. This section was pretty much left as it was. And also this part here. Steve, was this an addition down here, the risky injecting practices? Is that new or was that always there? I think that was always there, wasn't it?
The topic was there. It was just the problem injected by another.
Yes, right. Yeah. And you might ask about that, Steve. Is that you might ask somebody if it came up in conversation that you might explore it. So it's not necessarily something you have to ask about, but that you might listen for. Is that sort of more the guidance? Exactly.
Listening for it and noting it is the first step to what we might want to do with this information. If you've got the skills and the knowledge to actually explore that a little bit further, and it's safe to do so, then feel free. Great.
So this is sort of where we start getting into some more of the changes down here. I believe we've updated some of this in the child protection area, Steve. Were there a few changes to that section?
Yeah, children were present, but this has made it more explicit. Children are victim survivors or recognised as victim survivors in their own right. And in elevating the status of a child as a child who has a particular name and individual is the key part of that section, to really individualise a child's experience.
Yeah, and when we're collecting information, children's names and even their school, not everything's here, obviously, because it's a form, but they're designed to be prompts for you to listen out for and have a spot to record stuff. It probably won't cover every single thing that people are thinking of, but you might find somewhere in here that you consistently record that type of information. Being forced out of housing was another one to ask victim survivors if you've listened for that and it's come up, it's something you might explore, including things like staying in a refuge. That might also be a prompt to explore if that came up in conversation. Steve, down here, the finances piece, did you want to speak to that at all?
That's right. Whether you've got control over your own account and bank finances, can build a picture of what control may be present. And then further on, we talk about intervention orders again, which might mean repeating or just taking off the intake as normal practice would dictate. But certainly the idea that through that psychosocial area is to build up a picture where you're listening out for particular risk factors, and as we move forward, we'll become more aware of what those risk factors are, and build a picture in a non-adversarial, non-confrontational kind of way as to what which might be going on, helping you formulate, based on your shared understanding of family violence, what might be going on for this person.
Great. I'm aware we've only got about 4 minutes left of this entire presentation. I would like to see if we could answer a couple more questions if we can, but we'll see how we go. This is, I guess, the main area for changes here, and subsequent to this, there's also a safety plan built in. Now, these are in here to assist workers that aren't trained in MARAM as well, to sort of give you some prompts to think about. I would recommend that you review it all prior and work out, as we were saying before, what's your level of competency around this. Talk to your supervisor or your team leader about what you can do if family violence comes up, and what support you might need, just so that you're prepared in advance for the work if you haven't done much of it. But I think a lot of people in the sector will have done quite a lot. This refers to victim survivors only. We know that a lot of the people we see may be perpetrators of, or people that use family violence, and that is a whole other area. These aren't for asking people who use violence, just to make that clear as well. And these prompts are taken from the screening tool. So when we talked about routine screening of family violence, the MARAM screeners are built into this tool, which is the level below the brief and intermediate, isn't it, Steve? It's just sort of just recognising and responding.
It's really just to have that standard set of screening that we can standardise the approach, and those questions are a little bit different to what you might see in the MARAM screening, and that's what the working group and the whole consultative process decided upon that was appropriate for an assessment, an AOD assessment.
Yeah. If we pop down further, I'm just going to scroll past the safety plan so we can have a quick look at that. It tries to provide you with some simple prompts. Now, Steve, you have also mentioned that it may not be safe to do a formal safety plan, or it might be that you have a safety plan in conversation with somebody. So really depending on what's in front of, who's in front of you and what's going on, to what you might do.
Yeah, that's right. The perpetrator might be present in the room, and or whether they're face to face or over the phone. So talking to any family violence maybe would be difficult.
Yeah, and we don't advise that you do ask in the presence of someone else, just like you would anyway. Ask if the person's alone and safe to answer questions if you're doing it on the phone. Again, it might not be safe to provide the plan to the client. Here we are. This is what I was looking for. The built-in MARAM aligned safety plan. It's not the MARAM safety plan, but it aligns to MARAM. So it's a good one to use if you haven't been trained. There's some guidance here, but again, check within, do a bit of a self-assessment, reflection, and talk to your supervisor about this as well, about your level of expertise and what you will do. We've got the standard safety lines there, and even for male victims, there is the men's referral service. So we've really tried to cover off on all the various, I guess, touch points that you might need. Now, this does not have a specific Aboriginal LGBTQIA or disability service. You'd want to look that up in your area and make sure that it was appropriate. For some rural areas, that may be a telephone service, but just pointing that out as well, because that is where we have to provide appropriate and safe care for those people, and that can be a little bit atypical. You may want a secondary consultation around those groups as well. Steve, anything else we want to point out? Oh, it's 2 o'clock. We're going to get thrown out. Down here, this is a place for you to collect information about what you've done with MARAM. In your VADC, we're looking at whether the MARAM was used. That's the key one, and also if you do determine whether the person's using violence or whether they're a victim survivor as well. And there's ways of handing over and recording your actions here. which we've added to as prompts as well. Steve, did you want to talk to any of that? I think we're probably at the end of our session now. I'll stop screen sharing. Did you want to talk to that last part of the form at all, Steve? I'm just going to have a look in the chat, see if I can find anything.
Yeah, it's really just documenting what your conversation is. It's not so much literally going through each of those steps, but documenting what you've heard and what your assessment's going to be. And that assessment can be done in conjunction with the team leader, supervisor, and specialist family violence advisor as well.
Wow, and the comments in here, thank you so much for your time, everybody. I know a lot of people have got to rush off and you're a busy bunch of people. I really appreciate all the comments that you've made and your engagement here. You're such a passionate bunch and it's so appreciated. If there's stuff that we can feed back through VADA, we will. And if there's questions offline that we can answer, we might look at how we maybe distribute those through VADA. There's some email addresses for you, including feedback about the tools to Sheridan Byrne at VADA. She's a great advocate for the sector as well. Yeah, we just really thank you for your time today, and we look forward to the next phase of the project and engaging with the sector again around that. So thanks and have a great rest of the day.